Okay, so aortic aneurysms, dissections. It's usually the aortic aneurysm depends upon how big it is. Okay, the picture explains all this words right here, and it depends on where it is at. It's usually fatal. Okay, so the big one that we talk about when we talk about the aneurysm, an aneurysm can happen in any artery, right? So what happens here is the middle layer. What's the middle layer? Tunica what? Media. Weakens and then forms a little bubble. The outside layer, tunica what? External, right? So it forms this little bubble here, essentially, and it weakens the wall of the artery. Most of the time, a lot of the time, due to high blood pressure, right? People with hypertension is one of the leading causes anyway. Depending on if it ruptures, depending on where that is, it could be instantly fatal. So if it's up at the aortic arch, right, then that's going to be fatal, unless you're in surgery or really close. I've had patients with a leaky, they were just sort of leaking, and went to cardiac arrest, and they couldn't. I actually went to the OR with them and watched, and they couldn't find where the leak was. Right, so the patient just sort of bled out his thorax. Anyhow, due to the weakening of this vessel or this wall here, it could rupture. People live with aneurysms all the time, however. Reason that they would live with aneurysm is either their health is too poor for them to operate on it, it's too big for them to operate on. Okay, so it's like a ticking little time bomb in there. But you would definitely know, like an ascending abdominal aortic aneurysm, you would know if it ruptured because the patient would bleed out almost instantly with a rupture. Not a tear. You know, this picture here looks a lot like an explosion, okay? But they usually start to tear. They dissect first. And then so you look over here where you have a dissection, and again, the picture will explain most of this, but you have this severe, sharp tearing pain in the back, all right? Unexplained lower back pain. That was my first experience with an aneurysm. This guy was sitting out in his lawn chair and called the EMS, and he says, "Man, I don't know what's taking place. My lower back is killing me. I mean, it's really hurting." Fast forward a little bit, we get him inside, and this was as a paramedic student. So my preceptor was over me, and I was doing my assessment, and I looked, I exposed, I palpated that guy's abdomen, and man, it started pulsating, and the whole mood of the call changed. You know, because he thought, and I sort of thought that, hey, we're picking up this guy, we're taking him to the hospital for back pain, you know. He probably could drive himself up there or walk down the street. But we palpated his abdomen, that pulsating mass in his abdomen. It changed the whole outcome of the call. We really got busy after that. So low back pain is one of them. Pulsating mass on the aneurysm. If this is in the abdomen, you palpate the abdomen and it pulsates, then a pulsating mass could be the sign. That's why you want to look before you touch, okay? Make sure there's not a mass there, discoloration. Okay? But the dissection, here the inner wall here sort of starts to tear. Here's this nice layer of blue veil, and then all of a sudden this inner wall starts to tear. Right, and then blood sort of starts pooling down into that, and then eventually, once enough blood collects in there, you're going to get the mass. Some signs and symptoms of the dissection, aortic dissection, the tearing, ripping. The patient will tell you it feels like someone ripping me in half. And the pain is like 10 over 10 top pain. Okay, so tearing, shearing type of pain. These here can sort of be confusing at times. Like here, difficulty speaking, weakness, paralysis, very similar to a stroke, right? But one that we can do, because in our assessment we check pulses times 4, right? We want to check 4 pulse points, so we check bilateral radial pulses all the time when we do our assessments, and then so we would have 1 weak pulse. So 1 weak, you would have 1 weak radial pulse. 1 strong, 1 weak pulse. It's a big sign of it. These other ones can be somewhat confusing. The reason I have these in bold is that these are very classic signs. So this tearing, ripping pain, and this, the weaker pulse on one side. All right. Not too much for an aneurysm. Okay, if you suspect the patient has an aneurysm or an aortic dissection, it's just rapid transport. You know, ABCs, good assessment, find out what's taking place, do your good sample, OPQRST, right? But rapid transport. They need a surgeon, correct? So just rapid transport. You guys who were at last year, we probably spent 3 days on congestive heart failure, at least. You know, they were going to spend 3 minutes. Okay, it'd be a lot better. So heart failure, CHF, congestive heart failure, COPD. Like it says here, the heart is in failure, sort of, with broad terms. Okay, and due to that failure, it can't contract. It loses contractility, so it drops stroke volume. If it drops stroke volume, what does it do?
Drops cardiac output.
Drops the cardiac output, right. So the patient may go into failure due to a heart attack, hypertension, a pulmonary embolism. A lot of things could send the patient into failure. Chronic, because it's a COPD, it could just be chronic. Congestive heart failure. And part of it is Starlings Law. Starlings Law is this huge law that we won't go into at this level. But remember me telling you the rubber band law? That's the way that I learned it. So Starling, part of his law, part of the Starlings Law, was he said the heart's like a rubber band. It contracts, and as it contracts, this band will go back to its original shape. So here, if you're a visual person, you can put love dub, love dub, love dub, love dub, right? If the patient goes into failure for some reason, it's usually the term they use is hypertrophy, is that it enlarges, right? And the reason that it enlarges is that it's in failure where it's losing contractility. Now those myocardial fibers are being stretched out. So Starling said that this rubber band tourniquet will go back to its original shape once you to a point. And that point is at the point where we overstretch it. If we continually to overstretch this without it breaking, okay, at some point in time, it's not going to go back to its original shape. So it originally started here, right? Love dub, love dub, love dub, right? And now, due to failure, let's say this patient had a heart attack, that a large surface MI that created a loss of contractility. Now it's overstretching because it's filling with blood. It's not pushing all the blood out, or the normal blood volume out with each contraction. It's storing blood into the ventricles. So now it's overstretching that. And what Starling said, at some point in time, this won't come back to its original shape. So after it's overstretched, then you get this, right? Can you guys see the effect? Pretty much. It's just not coming back, so it's not going to eject the proper contents. Stroke volume's going to go down, and then cardiac output is going to go down. I know we spent a lot more time on it because there's a lot more involved in congestive heart failure, but not at the EMT level. Okay. So part of Starlings Law, the ventricles can't adequately eject the blood because they're overstretched due to the failure, due to the ventricles failing. You have left ventricular failure, which in right ventricular failure, you have right heart failure and left heart failure. And right heart failure will lead to left heart failure. Right? Most people start out when they're in CHF, unless it's just an acute event like a heart attack, they start out in right failure. Right? So the blood will back up on the right side. And if it's an acute event like a heart attack, then they're going to left ventricular failure. Right? So I think we went over this last class. You have this alveolus, right? Air's coming in here. You have this capillary, and then blood's going through here. So in left heart failure, in right heart failure, where's the blood back up into?
The lungs.
And in right heart failure, where's the blood back up into?
Oh, right. The rest of the body.
vena cava, right? And so if you track the vena cava down, where does it end up?
The legs. Well, legs.
Yeah, in the legs. You get cankles. Okay? So the patient will have lower extremity edema, and it could be in the legs, in the hands, in the arms. They can get edema in there through right failure. So right failure produces peripheral edema, okay? So left failure will produce what? Pulmonary edema. And it's due to this pressure. So in this capillary, we have a volume, and all of a sudden now there's a backup, and now there's more volume, and due to pressures in this capillary, because this pressure is now higher than the pressure out here, because there's fluid out here, right?
Mm-hmm.
So there's a pressure here. Let's just put X pressure. And then if you have Y pressure in here, if you want to do all that math stuff, right? Okay, so due to the backup, once this pressure exceeds, once this pressure here in the interstitial fluid is lower than this pressure, this fluid is going to diffuse osmosis through this into this space here. So now you're going to get more fluid here because the backup in this pulmonary capillary. So the pressure here, let's say this pressure, let's put a number on it, a hypothetical number. Let's say this, it wouldn't be that high, 6, okay? Let's say this pressure is 6, and this pressure is 4. Because the pressure laws, this is going to move through this capillary into this other space, because high concentration to a low concentration, correct? And it's just going to continue into the airway. And this is where we get our airway sounds, okay? The rales and bronchi. Is once that fluid makes the way into the airways and into the bronchioles, then we pick up the crackles in the bronchi, okay? And this will continue until we would change the pressure in the fluid, correct? All right? So right failure, low extremities, left failure, pulmonary. Okay, it doesn't really make a difference in your treatment at all, because you can't treat congestive heart failure past oxygenate the patient. That's very important, okay, to oxygenate the patient, but that's your limit on the treatment, is oxygenation. All right? In position, you can position the patient where they can breathe better. But definitely once this leaks out into the airways, gas exchange is decreased drastically. And then there's a normal, then this hypertrophic heart here, this bigger heart. When we went to UT Southwestern, you guys remember seeing that big flat heart that they had?
Yeah.
I mean, it was fatty. It had a lot of fat on it, but it was a huge heart. It's all stretched out. When in clinical sites, you could see it when they took an X-ray of someone with CHF, their heart would just cover it was huge. It would just cover it. It's so stretched out. It's so hypertrophic, right? And just due to that largeness of it, it's stretched out. And thanks to Starling, we know why. It just, those fibers are just pulled apart and they won't contract in the same force that they used to. So right ventricular failure, left ventricular caused by left ventricular failure, COPD. The other things that we see besides the peripheral edema is JVD, jugular vein distensions. You can palpate that big liver. Remember, normally you shouldn't be able to palpate your liver. This liver may be enlarged where you can actually palpate the liver. Okay? What we look for mainly is the peripheral edema and the JVD. Okay? And then left failure can definitely cause cardiogenic shock. And that's due to the acute failure. So we look at the charts again. Breath sounds, right failure only, clear breath sounds. Left failure, we have the rails of the bronchi. You have the peripheral edema in both, and the JVD in both. The pressures are usually normally high, okay, because you see hypertension in the CHF patients. You see a lot of common signs and symptoms. You see hypertension, irregular heartbeat. Anybody remember where the irregular heartbeat comes from? A lot of CHF patients, most of them have an irregular heartbeat due to tell lie. What's that? What's lie?
AFib?
Fib. Most of them are an AFib, which produces an irregular heartbeat all the time.
Okay.
It's regularly irregular. Okay. They have high blood pressure, and a lot of them have diabetes. So there's some common traits with CHF patients, chronic CHF patients. Okay. Acute CHF patients, not so much. Chronic CHF patients, AFib, hypertension, diabetes is the common trait with that. You look at these patients and they're going to take diuretics, some form of diuretic, because they take the water pill. They may call it. They say, "Oh, I take my water pill, make water." Okay, so they take some sort of diuretic. So you can look at their medicines as well. Like say they're unconscious. You can look at their medicines and pick up some of the past medical history, because they'll take a diuretic, and most of them will take a potassium supplement. Because if they take a certain diuretic, like a Lasix, the potassium goes with it, so they have to supplement they have to take a potassium supplement, because their Lasix takes the potassium out with all the urine. Okay. Some don't. Some diuretics are potassium sparing, so they don't have to take a potassium supplement. All right. And then we have this lady. She doesn't look in too much distress, but anxiety, JVD, like I said, sort of late. Rails, bronchi, crackle, shortness of breath, dyspnea, increased work of breathing. She's having to breathe through all that fluid, right? She's having to breathe harder to get through the pulmonary edema. You might put out here Ascites. Don't ask me how to spell it. I think it's like an A. Ascites. This is where they get fluid in the abdomen. Right? So the fluid, third spaces. This is a form of third spacing too. Okay, it's not in its original place, so it spaces out, third spaces. But so you have this ascites, this abdominal swelling, and it is painful. It feels like a watermelon. You palpate their abdomen, it's really firm, it's very tender, right? So they can get fluid there as well. The cankles, they need to sit upright because of the fact that they're full of fluid. They have pulmonary edema. They're going to sit upright. You lay them flat, they feel like they're doing what? Drowning. Right. Pressures just depends. This pink sputum, remember the Starbucks picture? The froth from the Starbucks. Okay, they could have that if they're not intubated. The picture we had, they were intubated and it was coming out the endotracheal tube, but it running down their face. So it was like the kids used to play with their spit, you know, when they put a little spit and let it run down their face, right? Did y'all ever do that?
No.
Bet you did. You just don't remember. But anyway, the pink sputum comes from the capillaries, the pink part. It mixes with the sputum and the blood, makes it sort of pink. It does look like that froth. Have y'all ever actually seen it in clinical?
That one, that lady had it. It was in her, it was coming out of the tube.
Yeah.
From
Oh, okay. Yeah. So you get that tachypnea, fast breathing, fast rate, cyanosis, late sign, confusion. Where's the confusion coming from? Not enough what?
Oxygen.
Oxygen, right. Get a little hypoxic. Okay. So recognize the signs and symptoms. Your treatment for congestive heart failure would be position them in the position of comfort, which would probably be about a 45-degree angle. Some nice pictures of some cankles there. JVD, big, huge, jugular vein distension. Okay, like I said, it's a little bit late sign. Check for jugular vein distension in a non-trauma patient. You'd sit them at a 45-degree angle and then turn their head to the side, and that's where the JVD would show up. So treat them. Maybe it's as the chest pains, the MI. You may have to bag them, suction. If they have that Starbucks thing going on, you have to suction. Okay, the pink sputum. The guidelines, 2010s. Remember, we evaluate the need for oxygen. We just don't give oxygen just to give it. We evaluate the need. Most of the time, these guys are going to need oxygen. All right, and then consider CPAP. Open up those bronchioles, force that air down in there. So again, fairly easy treatment for CHF. The only difference between here and ALS is advanced airway intubation, and then we could give them a diuretic en route so they could start that process to get rid of that fluid, but it's not much else. Okay? And you want to be careful giving a diuretic in an ambulance too. If you're a long way out, it's sort of bad to give a diuretic when you're 30 minutes from a hospital, because they're going to need to urinate really bad in about 10 minutes or so. But you guys don't have that concern. Everybody good on the treatment? It's pretty easy. Oxygenate, transport, maintain their airway. Questions there? Everybody good? Okay. Hypertension, high blood pressure. For some time now, we've stopped treating asymptomatic hypertension, which means what? Asymptomatic.
They just have high blood pressure.
Yeah, without symptoms. They don't have any symptoms. Yeah, they just have, their blood pressure is high for some reason, but they're asymptomatic. They don't have any symptoms. Some symptoms would be chest pain, shortness of breath, dizziness. Dizziness is a big one, right? Nausea. That high blood pressure makes them nauseated. You can see it a lot of times in their face. Their face will be really flushed. The skin will be flushed. Okay. Of course, you could just take it and find out, right, if they have high blood pressure. But asymptomatic hypertension, if this patient here, let's say they had 220 over 110, I mean, that's up there. You know, so I would be concerned with the stroke, but hey, if they're asymptomatic, we just don't treat it. We treat asymptomatic hypertension now with rest. We used to treat it all the time. We'd give them this medicine that dropped their blood pressure quick, and we found out that was giving a lot of people strokes. So they stopped doing it. All right. So here's just the definition: one greater than 160 or diastolic greater than 94. All right. Your treatment would just be to transport, monitor, oxygenate if necessary. Probably not the need for oxygen there. They're hypertensive. They're not having these multiple symptoms like shortness of breath or whatever. If they were, then you would oxygenate them, right? Evaluate the need for oxygen. But this patient here, most of the time they just transport. There's nothing that you can give EMT-wise for this patient. Now, you do have a medicine that's in your arsenal that you could give for hypertension. What would that be?
Nitro.
Yeah, nitro. Because nitro will always drop the blood pressure. ALS-wise, nitro is the first-line drug. So if I have a patient with symptomatic hypertension, they give you a number in your protocol. So let's say that person at 220 and 220 over 120 or whatever. And they were symptomatic. The first-line treatment is nitro. Give them a nitro drop to lower their pressure. Try to slowly lower their blood pressure. But EMT-wise, BLS-wise, you guys transport, monitor the airway, do a good assessment always, right? Cardiac arrest, any questions there? Start CPR, right? A lot of your questions on the National Registry, on the cardiac, I think it's like 30% of it, if not a little more. A lot of them are CPR questions. Okay, CPR, AED questions. Don't fail the National Registry because you don't know CPR or the AED, operations of the AED, right? So we'll review that for sure. But that has happened. I've had students take the test before, and they just get barraged with these CPR questions, and they didn't review their BLS before they took the test. That's what did them in. Otherwise, your tests those type of questions are going to be about the nitro, how to administer nitroglycerin, okay, and the need for oxygen. Remember that even that cardiac patient, we evaluate the need for oxygen, right? So make sure that cardiac arrest, recognize it, recognize this patient that potentially can go into cardiac arrest from this acute coronary syndrome, right? And if you're having a patient that their chief complaint is chest pain, you should always keep it in the back of your mind that they could go in cardiac arrest. That way you're prepared. Okay. By the way, that one question: why do we turn on the AED before we apply the pads?
I have no clue.
Other words, the AED say apply the pads.
No, it's simpler than that. If you think about it.
Forget to turn it on if they put the pads in. So you just like
What happens when you turn the AED on? What does it go through? You turn it on, what happens? No. I mean, right? You turn it on, and then what takes place on every AED? You may have never noticed, but it makes sense for that question. When you turn it on, it goes through a self-check. It takes a few minutes for it to go through a self-check, and then it tells you to apply the pads. So if you apply the pads and then turn it on, what's it going to do? Make you wait. Exactly. We don't want to wait. So now I turn it on, let it do its self-check, okay? Put the pads on, and then once it finishes its self-check, I plug in the pads. There's no wait time, because I'm doing something all the time, right? Does that make sense? Yeah, and that's what you want to do. You, in cardiac arrest, you want to be doing something all the time. So just like in the morning, you turn on your shower, what do you have to wait for?
Hot water.
Hot water, okay? Everybody that I can think of waits for hot water. Turn on the shower, do something while you're waiting for the hot water. Okay? So, anyhow, most pediatric patients don't go into cardiac arrest due to some sort of cardiac syndrome, okay? Acute coronary syndrome. They go into it because there's a heart defect or a respiratory problem. If they don't have a heart defect, most of the time they go into, besides trauma, most of the time they go in for some sort of airway or respiratory problem. So keep that in mind. Think when you're thinking you have a child in cardiac arrest or a pediatric patient, think of airway, respiratory, unless you find out otherwise. Okay. Geriatric patients, which I'm not one.
Are you sure?
Yeah, I'm sure of that. Yeah. Yeah, I've got a while to claim that title. I could buy my AARP card, but I'm not geriatric, okay? So they do, I mean, that's the old person, the elderly is going to be your number one patient, right? Especially in cardiac arrest, because they're old and they're sicker, typically, okay? They have a lot of years on that engine. So they're going to be typically a little bit sicker, and then they're going to experience these type of heart failures and chest pains, okay? So look at that. We have a whole chapter on geriatric care towards the end. And then also, because once these geriatric patients, they get older, they start having more medical problems. As you get older, I know that you don't think of this at 17 or 18, right? But as you get older, you have more medical issues, okay? Everything they say that happens after 40 is true. Okay, so live it up till 40, because everything happens after 40 is true. Your metabolism slows down, you start waking up with these odd pains, okay? Your sight goes, your hearing starts to go, your digestion slows down, okay? Women, every time you laugh really hard, you urinate on yourself. We had the last laugh, okay? But there's a lot of different problems with geriatric type patients. As you, in 40s, not geriatric either, but you start having these multiple problems, okay? Trauma may be a little bit more predominant because of the risk of fall. Or have you seen Grandma drive? Yeah. Granny driving down the road. Her insurance is $3 a month, but she causes all the wrecks, you know. But they.
I saw one lady brushing her teeth. She was going really slow. My mom's like, "We're gonna go around her." Literally, she was like brushing her teeth. I was like, "Okay."
Wow.
And she had to be like 70.
Chew gum. Right? History of asthma, COPD start to come up. You can avoid a lot of this, okay, now, because you're young, pre-plan, stay healthy, right? But lead an active lifestyle. You won't have a lot of these problems. A lot of the health problems are either from a lot of the health problems in the geriatrics are either from their work that they've done. See this person that has 70, when they were working, like when you guys, they worked hard. You know, I mean, I'm not saying that you guys don't work hard, but they work more physical. Okay, and through technology, we have less physical work now. There's a robot that does almost everything, surgery included, right? So a lot of their problems, a lot of their health problems come from their youth when they had to work with their hands so much. Okay, so or they led an inactive lifestyle. We're like horses. We're designed to move and be upright and to be active. You can eat all that food you want. You know, they said, I've known patients and people who were in their 80s and 90s, and they had beans and bacon and eggs, and I mean cooked in butter, fat, right? Every morning. I mean, they ate what people now would say, man, that's a horrible diet. Ate it every day of their life, but they were very active. You know, that's the difference. They didn't eat all that stuff and go sit down on the couch and watch soap operas all day. They got up and worked. They remained active. That's very important. Also, to keep your mind active as well. Not all the cases, but a lot of the cases you'll see that it's just a glitch in their lifestyle, that they should remain active. So always do, definitely consider the dispatch information. If they're having chest pain, do yourself a favor on the way to the call. Think that they're in cardiac arrest. That way you will be prepared when you get there and they're in cardiac arrest and they're not just having chest pain. Okay? It's a different mindset if you go into the house thinking that the patient's in cardiac arrest. You're thinking worst to least, which is good. You're thinking cardiac arrest, that way you're prepared for it. And it's better than going in the house and you think someone's up having chest pain, you don't give this patient some oxygen and nitro and go on your way, and you go into the house and someone's doing compressions, right? You're in a different mindset. Think CPR, and then, everything else you can downshift. Much easier to downshift than to speed up. Okay? Size everything up, do good ABCs. Remember, if they're in cardiac arrest, always begin CPR as fast as possible. Okay? Get the AED, ABCs, oxygenate, all that same. This just goes down your patient assessment skill sheet. All right? OPQRST sample. Okay? Fibrolytic therapy. Anybody know what that is? It's a little outdated. Let me use the slang term, and you might know clot busters, where they give them a medication to break up the clots. You know that clot in that coronary artery. They may give them a medication to break that up. All right. Now, really, the standard of care is to take that person to a heart center, which has a cath lab. Okay. So you would take this patient to maybe Big Baylor, Dallas Regional. They're a heart center. They have a cath lab. Lake Point, obviously Parkland, Methodist. All these they have Presby Dallas. Okay, they have cath labs. So yeah, they still do the clot busting stuff. However, now they're more in line to let's take this person to the cath lab. We can see the clot. Plus, busting that clot up makes little clots, and that's dangerous at times. Don't really want to do that. I'd rather go to the cath lab. And then, of course, that's like we talked about. Don't downplay the symptoms. I've had patients I've been talking to and go into cardiac arrest. So you have to be prepared for that all the time. Contraindications. This is a clot buster, by the way. Contraindications would be any kind of bleeding disorder. Okay, the fibrolytic therapy, okay, it's a really big, it breaks that clot up, but it really thins the blood down. So you wouldn't have any sort of bleeding disorder, any sort of recent surgeries. You know that they couldn't give that to them. But again, if you take them to a heart hospital, designated heart hospital, they're going to a cath lab. It's much better to look at the clot than to break it up, put a stent, balloon it. Patient angina lasting 20 minutes, right? Worsening, nocturnal angina, what's that mean? Nocturnal?
It happened in the middle of the night.
Night, right. So maybe that unstable patient, unstable angina, wakes him up in the middle of the night, where it keeps getting worse, it keeps getting more frequent. Unrelieved, so it's unrelieved by rest or nitro. You can give nitro 3 times over 5 minutes, checking the blood pressure in between, okay? But three over, I would say 15 minutes. You give it every 5 minutes, but checking blood pressure in between. But so it's unrelieved. This sort of tells you here that, hey, this person may be having an MI because they have unrelieved angina, right? And unrelieved chest pain. Or it lasts longer, lasts 5 to 10 minutes. And then we just go through our physical exam, the same physical exam. Atypical means what?
Not normal.
Not typical, right? So, yeah. So that female, that diabetic patient, complaining of nausea, that's their only complaint. Diabetics and any pain above the belly button is cardiac related. Okay, I think that of all patients, you're having anything abnormal above the belly button, I'm always thinking cardiac related until proven otherwise. And that way, these atypical presentations, you're sort of ready for those. Okay. And then just go down through your physical exam checklist. Just some pictures where the pain sort of radiate. Here's substernal, middle of the sternum, radiating down the arm, the neck, the back, right, shoulders. You have this radiating pain. And then just continue your physical exam with your vital signs. Here, like if you were to have a cardiac scenario in your medical skills test, then you would run down through the skill sheets. I'm going to give you the questions. You got you guys have the questions from last year?
Yeah. I just looked at them first.
Yeah, so you would ask those type of questions in your scenario. Those would be the type of questions that you would ask. They're just based off the signs and symptoms. I'll give everybody a copy just in case to practice on the different questions. As you ask the questions as you work down through your physical exam. So sudden diaphoresis, cool pale skin, shortness of breath. Any of these could be cardiac related. And then the pulses, the nausea, vomiting. Nausea and vomiting is a big one. If they're in some sort of circulatory compromise, the body's, remember that autoregulation, the body's going to pull the blood away from the gut, and that's where the nausea comes from, when it pulls the blood away from the stomach and the intestines. Ensure the patient that you know where to go to take him to the hospital. Remember, analyze the need for oxygen. That's a big one. It's a big one on the exams too. Okay, and big in real life. If the patient has prescribed nitroglycerin, you can help the patient with their prescription. Okay, on a written test, it's either going to appear like this, assist the patient with their nitroglycerin, or administered nitroglycerin. All right. So on the testing part of it, everything is a standing order, as far as I know now. It used to be you had to ask permission for medical control. You had to gain medical control. So you may see a question like that. If you want to give nitro, you ask for medical control, then the nitro. Okay, we'll go through those scenarios. But I believe now they've switched everything around where everything is a standing order. So your arsenal of medications that you have is a standing order. So you would be able to give nitro. Aspirin, check, make sure they're not on any other blood thinners. ALS is a big thing because there's more treatment that ALS can do. You give morphine to reduce the preload, right? Do a 12 lead to go ahead and confirm that if there's a STEMI, right? So there's ALS on the chest pain. And again, this goes back to the skill sheet, right? Request ALS backup, get that going, when you go there. Always reassess. Reassess according to the chief complaint. Reassess after you do an intervention like oxygen or nitro. Reassess that. Are they breathing better? Is the pain less? This is why you have to have a baseline on the pain, right? If you don't have a baseline on the pain, and you start giving medications, then you don't know if it's better or worse. It's harder to go back, if you didn't have like on that 1 to 10 scale, if you forgot to do that, you give a nitro and you say, oh yeah, what was the pain before the nitro? See how awkward that is? So it's always good to get the backup. To get the baseline. Get a good baseline on the pain rating so you can reassess. Alright. Questions? Everybody good with that?